Welcome back, listeners. This is episode 6 of the Life in Bomb City podcast. I'm Aaron Favor.
And I'm Dr. Beth Rodriguez.
We're sitting here with our guest, Representative For Price, Texas District 87. Welcome to our show, sir.
Thank you. I appreciate the invitation to join you.
Yes, sir. Beth and I decided last year, I believe, to record a trilogy dealing with the opioid crisis, and this is the first episode of that trilogy. We'll be bringing you episodes on both law enforcement and treatment as well in the upcoming weeks and months. Just to give everyone a little bit of background about you, sir, so that those who may not know about you or your political life can be a little bit more familiarized. Representative Price is a fourth-generation Texan. You're from the city of Amarillo and represent District 87, which includes Carson, Hutchinson, Moore, Potter, and Sherman counties. Representative Price is incredibly well-respected as a legislator in the state of Texas and the political world of Austin. Representative Price has chaired several committees that are critical to the agenda of not just our district, but of the entire state of Texas. And one could argue the national agenda, particularly with his work on the House Select Committee on Opioid and Substance Abuse, which he was tapped for by former Speaker of the House, Joe Straus, and which is what we're here to talk to him about today. In 2019, Representative Price was appointed to chair the House Calendars Committee by Speaker Dennis Bonin and serve on the House Natural Resources Committee and the House Public Health Committee. Additionally, in what I would call a symbol of how well-respected he is, he was chosen to serve on the House Redistricting Committee, one of the several posts that is apparently keeping him busy traveling around the state to listen to concerns of Texas citizens. He co-chairs the Health and Human Services Transition Legislative Oversight Committee and was recently appointed to serve on the House Select Committee on Mass Violence Prevention and Community Service. You are a very busy man.
No kidding.
It is a busy time right now. And this interim period is actually a really good time for feedback from Texans about what policies they want to prioritize in the next session. So this is an active time for all legislators for sure.
Well, I definitely want to reemphasize it's such a pleasure to have you on the show today. Thank you for taking time out of your busy life to be here. Beth and I have read the published interim report to the 86th Texas Legislature from your chairmanship of the House Select Committee on Opioids and Substance Abuse, your recommendations for legislative action from the last session that began in January of this year. Can you talk about a few things you learned on that committee related to opioids and substance abuse that proved to be challenges?
You know, in Texas, we have such a broad problem. Statistically, it may not always jump out at folks because we have such a large population, such a diverse population. Our record keeping and methodologies are somewhat different than some other states, certainly some smaller states. And so, you know, it may not jump out to a lot of folks that the opioid and substance abuse addiction issues in Texas are as severe as they actually are. How many people are affected, how many days of lost work and productivity and overdoses actually occur in Texas. So it was quite eye-opening to hear the testimony, learn the data, kind of see how states differ from one to another and how hard it is to compare apples to apples in some of these areas. And, you know, it is amazing that, you know, some very little steps can be taken to make some progress in substantial ways. And so, you know, the committee was good because it heard a lot of big picture ideas that we could address, but we also heard some very easy steps that could be taken, some non-legislative steps that could be taken as well, and some of those are actually, you know, underway as we speak.
So looking at the numbers after we looked through the whole report, I noticed that a lot of the percentages in Texas were right along with the national averages on opioid and substance abuse, and even in some places higher. Is there a reason why that we think Texas is on the same percentage of that?
It was interesting to me, too. You know, and in some cases, depending on which, I guess, data set you were looking at, some of our smaller, more rural communities really stood out. So Amarillo, for instance, Longview, Texarkana, Odessa, I think those were 4 of the cities that were pointed out by a national publication that, you know, suffered some statistically higher than normal overdose rates because of, you know, the number of prescriptions that were issued to communities of relative small size. Maybe, you know, there's not as significant law enforcement presence in those more rural communities like the one we're living in. Mm-hmm. Perhaps there were some other issues that contributed to that, but it was interesting. Texas, you know, is a giant state. We have, you know, just a huge diverse community, and we're joining a lot of other states as well. So if somebody wants to go doctor shopping, And you live in a community like Amarillo, Texas, it's not hard to drive to New Mexico or to Kansas or to Oklahoma and come back. And we're taking some steps that hopefully will alleviate some or mitigate some of those problems. But yes, I mean, I think that it was a little surprising. And Texas, as I stated, was, not an exception to the opioid crisis nationally.
In the formation of public policy regarding drugs, it seems that on the level of the national government at least, they've taken one of two or both routes, attacking supply and or attacking demand. In the committee, did you find this to be a reality? This report is so detailed in its recommendations for legislative action. I'm curious as to how you were able to break down the complexity. Can you visit with us about that?
That actually was really a difficult thing to do, is to break it down into measurable and digestible segments that you could make some legislative headway on in a 140-day legislative session. Because not everybody obviously served on the select committee, so they didn't have the background in education. Maybe the entire committee did. And remember, this was just a House committee, so it didn't involve the Senate at all. So you have to, educate your colleagues in both chambers and certainly, do the best you can to make, the most progress possible in a very short period of time. So one of the things I think that we tried to address was, yes, both, the supply, but also a broader educational prioritization, both on the, side of physicians or prescribers, as well as patients. And we took some steps to actually do that, because I think there's a growing awareness, and there needs to be, of the addictive qualities of opioids, especially for acute pain. What we did not want to do was just prohibit the use, legitimate use of opioids for pain management in chronic cases. And we had a lot of folks testify at the Capitol that were very nervous, very concerned that they were suffering from chronic conditions. They didn't want to see this taken off the table for them as an option, and that was never the intention. But if you could, separate chronic from acute, and you could separate some issues like proper education for those that are prescribing, whether they be dentists, whether they be PAs, whether they be, physicians. We need to strengthen the prescription monitoring program. We had to, really focus on education and awareness. We had to focus on the use of antagonists, or, the drugs that are used to combat an overdose situation. That's something we could do. And then the supply is something that, I think we had to focus on, and medication take-back programs and things like that to help everybody understand that, the supply out there is troubling or problematic, because people will self-medicate or sell it on the black market, and it just exacerbates the problem. So, yeah, we tried to take a lot of those and break them out into segments that we could actually make progress on, and I think we did.
Well, it's funny because I was looking at all of this, and when we were looking at the DSM, which is a Diagnostic Statistical Manual for psychological disorders, substance abuse was first in the 50s, was actually labeled under the sociopathic personality disorder. And so people weren't being treated for the substance abuse, they were being treated for a personality disorder. And it wasn't until 80s that they actually decided the substance use disorder was now a diagnosis. And so there was one act that I had found that was passed in 2018 in June, and it was the Overdose Prevention and Patient Safety Act. Did you hear about that at all?
We did hear some reference to that. Yes.
Yeah, and it was, and I figured, because a lot of the stuff that you guys talked about really did play into, they called it the OPPS Act, because it's a lot easier than saying everything else. But they were really worried about not just the fact that there's a stigma for people who have a mental disorder and a substance abuse disorder, but also the idea that we need to know how to help if you are overdosing, because people don't. And that's kind of one of the steps, is that we wouldn't see death as much if we had more education about what was going on.
No, that's correct. And that was a reason why we actually focused a lot on the educational component of this, because from both sides of the fence, whether you're prescribing or receiving, everybody need a little higher knowledge and awareness of the consequences, and maybe what some symptoms look like, and what you can do in cases of an accidental overdose, for instance. And so that's important. And there were several pieces of legislation that address that, from from the continuing education requirements that prescribers have to take to what we now see as a 10-day limitation on the prescription of opioids in Texas for acute pain. That's somewhat controversial, I guess, but it is a step that the legislature felt necessary. A lot of insurance, especially private insurance companies, were already kind of taking some measures on their own to just limit the supply, again, that we talked about, as well as forcing that discussion between a prescriber and a patient that, you probably don't need 30 days worth of a medication to treat, a week or 10-day condition. Sure. And, it was interesting. Dr. Sheffield, who's a colleague of mine in the House, served on the committee. And he sort of educated the committee and spent a lot of time talking about the development of the fifth vital sign years ago, and how, there was a time probably 25 years ago when physicians were highly criticized for not managing or treating pain very well. And then that sort of coincided with the development of the fifth vital sign, where patients would be asked, on a scale of 1 to 10, what is your pain? And pretty soon, I think, when pain was identified at a 6, 7, 8, whatever the measure may be, and opioids were actually being marketed and developed and pushed at a much more aggressive level. Mm-hmm. This all happened at the same time. And so I can't help but think that the development of the fifth vital sign, the criticism of physicians, the pushing or, marketing or just desire to use more pain management medications all were occurring at the same time. And so there was a huge oversupply or, maybe overprescribing phenomenon occurring, and at a time when I think patients weren't quite as knowledgeable about the side effects or, the addictive quality. So I think we have come a long way from where we were. We have a long way to go, but hopefully, the awareness and educational aspect of all this is going to be, bearing fruit here for us in the future.
So what are some other past examples, aside from the one that Beth has just mentioned? Her example was at the national level, perhaps adopted by either our state and prior legislatures or other states who are also tackling these problems, but maybe in a different way, using different methodologies. Did this committee or its members ever travel out of state to visit and meet with parties that have seen growth and success that our state can model off of? And what is something that Texas may be doing that other states might want to adopt in the future?
So the committee itself held all of its hearings in Austin. Each individual House member who served on the committee undertook their own, efforts to talk to folks out of state, or in some cases travel out of state. We had members from all regions of the state, some that lived down in Far East Texas that border Louisiana. Obviously, we had members that did their own traveling and had meetings both nationally in different locations, participated in conferences and things like that. But we held all our hearings in Austin. And so we didn't have the budget to actually get out and do a much more aggressive schedule. And it was a select committee, so it really met for a very limited period of time. So we felt like we needed to kind of do that in Austin just to accomplish what we were charged to do. I think some of the things that Texas was working on that we have passed that other states are either in the process of working on or maybe have done in different variations is like at one level, the prescription monitoring program. Now, that is something that I mentioned just a second ago. It's often referred to as the PDMP or the PMP. And what that is a database that is checked before a physician or a prescriber is going to prescribe an opioid. And if the patient is already in the database, is having received a prescription, say recently or from another provider, that will show up in the database. So it might be okay, but it also might be a red flag that we need to have a further discussion about why you're coming in for another prescription when you just received one, recently, or maybe your veterinarian prescribed one, or maybe your dentist had prescribed one, or whatever the case is. So it may be totally legitimate, but it may not be. And it also requires the pharmacist, before dispensing the opioid, to double check again in an effort to make sure that there is no, overprescribing problem or abuse of the system problem that is occurring. And there are algorithms built into that database so that if multiple prescriptions over a shorter period of time or showing up with the same person, it will alert the prescriber so that you hopefully cut down on that. And so there's some efforts there to actually not just, strengthen that in Texas, which it won't be fully effective until the early part of 2020. It's already being established, and you can check it, but it's not required at all those levels I just mentioned until I think March of 2020. But other states, it would be great if we could actually communicate very well across state lines and make those databases talk to each other, because those are being developed as well and utilized in some states, some bordering states as well. So that, would really be a useful thing in those instances where somebody may be trying to quickly obtain prescriptions in multiple locations in multiple states, just to have that supply, whether they're going to use it for themselves or sell it, or
Right.
whatever the case may be. So that's something that I think we made tremendous headway on, but and other states are working on it. However, everybody's kind of in a different stage of development and progress and implementation. So hopefully we'll see that coordinated effort, occur a little more significantly here in the near future.
Interesting.
Is there anything that you guys really worked on, some initiative or something that you were really like, yeah, and it didn't make?
Of course, there always
Yeah.
is. That the legislative session is so short in duration that there's always issues that you feel like, should be just completely agreeable to everybody. And generally that's never the case, because there's always some group or some person or some, group of people that don't always agree. And that's just kind of the legislative process. For instance, I had a bill that not only had some limitations in it with regard to the prescription of controlled substances, including opioids, but it also had sort of some requirements on the prescriber, for instance, a physician, to have a conversation with their patients about the addictive qualities and to document that in their record, and then to follow up on that. And so even though I think that educational communication between doctor and patient is a really good idea, and probably most doctors do that, the physician community really didn't like being told by the legislature that you're going to have to do this, and you're going to have to document it. You're going to have to show that, this took place. And so, and I get that, it's kind of it's a commonsensical thing to do, in my opinion. It's a good best practice thing to do, in my opinion. But the fact is, they just didn't necessarily like the idea of a physician being told what to do by the state legislature. And I also understand that too, because in their independent medical judgment, they need to be able to operate the way they feel best. And so, that's a pretty basic example. But yeah, I mean, there's some things that certainly, we would like to have seen accomplished that we just didn't quite get to the finish line. But this is a huge issue that is not, going away anytime soon. It's a multi-session issue in many cases. We'll go back and see, the progress that we made. Is it working? Does it need to be adjusted? I mean, there's always new issues. There was one that just came to mind, which I would have never thought about prior to last session. But, we encourage individuals, especially those who have family members who are maybe on prescription opioids for pain management, to have an antagonist available, like a Narcan or a naloxone, so that if their family member overdoses, that they have some drug available to help them until an EMT can arrive. And we realized that in some cases, because they had obtained that via a prescription, that it might be affecting their ability to obtain life insurance, because life insurance companies were looking at that saying, well, if you're getting this antagonist, that must mean you're on opioids or addicted. And if you're addicted, you're going to be an insurance risk. And so we're not going to offer or underwrite your insurance.
Did that bill, we were talking about that bill today,
Yeah,
weren't we?
I think so.
This
Yeah.
morning.
Yeah, about the insurance and everything that plays into it. Yes.
It was a very interesting issue, and it did
Yes.
pass. And so, we were able to, basically not penalize in Texas those individuals who we've encouraged to have some, very useful medication on hand in case there is an overdose situation. It might not be their own. It might be a family member, somebody they live with, or whatever the case is. And so issues like that are issues that come up every session that, just consequences from things that you do that you don't necessarily anticipate having to deal with. And it happens on a whole host of issues, but I think that's a pretty good example of something that
I think we were visiting about
We
that
were.
in the implementation of public policy oftentimes one of the things that you guys try to project or think about when you're strategizing and when you're doing lots of critical thinking and problem solving. What are going to be the unintended consequences of the policies we're putting out? Because they're going to be there. We don't know what they are. We can't know what we can't know. And
that's one of them.
That's correct. No, it's absolutely true. You know, there were also a lot of efforts this past session to focus on maternal mortality and morbidity, and you know, Texas has suffered, you know, in some areas in this, in you know, protecting mothers, and you know, statistically there have been some areas where it's not you know, it's not good for us, and so we needed to really focus on, you know, why that's the case and what can we do. And so, you know, in an area of substance abuse and addiction, recognizing that might play a role in some of the poor statistics that were, you know, reflecting maternal mortality and morbidity in Texas, we had established a task force so that they would collaborate, and required that collaboration between the task force and the Department of State Health Services, so that we can really come up with some solid priorities and policy initiatives that will prevent that, you know, and maybe that will help play a role in improving our maternal mortality and morbidity statistics in Texas. So there's lots of issues out there that relate, you know, to this. And Beth, you brought up sort of the co-occurring condition between mental health and substance abuse, and you know, it's quite common. And you know, sometimes it starts out as a substance abuse issue that turns into more of a mental health issue, and sometimes somebody with suffering a mental illness can become addicted to substances. And so a lot of these issues have to be treated holistically and together, and not recognized as just one or the other, because they happen together in many cases.
I love that you brought that up, because I actually looked it up, and what they're saying, like worldwide, not just United States, but worldwide, there's 50% of mental disorders are affected by substance abuse, and 30% of alcohol abuse, and 53% of drug abuse have at least one mental disorder.
I'm not surprised.
I know.
Yeah.
So everything's co-occurring, which, I mean, could play into the idea that we don't just need to look just at the drug, but we need to look at something else. We need to, you know, kind of help out on all fronts, so we don't see the issues just continuing.
Yeah,
We can't put the Band-Aid on and be like, oh, everything's fine, because it's still bleeding.
That's
right.
correct.
And that's kind of this idea that we talk about all the time, is like, where is it? Like, if we're looking at the legislative part, is that going to fix everything? And it's not. But it's a good step.
That's
but
right.
we have to continue to do the treatment part, the education part, and everything else that goes along with it.
Yeah, there's a lot of pieces to that puzzle, and I think you're right. There's no easy, you know, answer, or else it would have been done a long time ago, for sure. But recognizing, I think, is a good step forward that, you know, many of these conditions are happening jointly or co-occurring, and, you know, you can't break them off into silos and just look at them in a vacuum. And I think we're doing a better job overall. One, you know, destigmatizing mental illness. I mean, there's still a lot of work to be done there, but I think we're light years ahead of where we were even just a few years ago on that. And when it comes to, you know, whether it's an opioid addiction or another substance use disorder, you know, whether it's self-medicating with other drugs, it's really something that, you know, if we view together, you know, it's all part of I think the trend to integrate treatments, you know, physical health, mental health together. It's going to be more successful when we do that. And so I think we'll see a lot more of those efforts, and both at the medical school education level and in the actual practical treatment of some of these conditions.
Yes. I'd like to touch on something that's a same issue. We're talking about a really wide playing field here, but within criminal justice, another co-occurring thing happening regarding drug use and the committing of crimes. Judge Reyes, in the report from the former president of the Texas Association of Specialty Courts, the role of specialty courts in being able to deal with some of these co-occurrences of people being on drugs while they're committing crimes. I'm going to throw some statistics out there from the effectiveness of specialty courts in Texas, and then ask you to comment on them. So 75% of specialty court graduates remain arrest-free, a 40% reduction in crime compared to other sentencing options. 78% of graduates obtained retained employment. 21% obtained a high school diploma or GED, 12% enrolled in college, and 14% enrolled in vocational training. So it also seems that specialty courts save the state money and communities money. Says every dollar spent on specialty courts equals $3.36 in avoided criminal justice costs alone. Could you comment on some of those things?
Sure. I think, the use of specialty courts has been very successful in Texas. We have a number of different specialty courts. They've really developed over a course of a number of years. Recently, we have drug courts, we have veterans courts, we have, lots of different types of specialty courts that really are very unique. Not every community has them. Often they are funded through different revenue streams, quite commonly through the governor's office, but it also requires sometimes buy-in at a local level, county level, for instance, to fund, and you have to have judges who are willing to participate. And so the statistics you just quoted are indicative of the success a lot of specialty courts have had, especially in this area that we're talking about. So often we see repeat offenders go in or enter our criminal justice system and cycle back out and then back in again and back out and back in again, because what they really have needed was some guidance, some resource, some treatment, not necessarily incarceration. A lot of these are nonviolent offenders who are picked up for a Class B misdemeanor, but it results from an addiction to a substance that has caused some very odd behavior, and that's not necessarily going to get better by just spending a short amount of time in county jail and coming back out onto the street and then going back to county jail. So recognizing that, we have strengthened the use of specialty courts in Texas, although there's still quite a bit of differences regionally as well as from a funding standpoint. So there's work to be done there if we're going to make that more available to all 254 counties. But we have also created some grant programs in Texas specifically for jail diversion, which can be used in connection with specialty courts, and other programs that really work hand in hand with the type of objective that many of our specialty courts are trying to achieve, which is successful graduation, treatment. Let's move people who don't need to be part of the criminal justice system out. It's better for those folks individually, and it's a big advantage to local taxpayers, quite frankly, because they are footing the bill for a lot of the folks who are languishing in our county jails awaiting competency restoration or treatment and things like that. So I appreciate Judge Reyes coming to testify, because he's quite an authority on specialty courts, and we had a number of folks give us testimony about the success that they are seeing in their specialty courts regionally. And I really feel like there's, once you see some of these graduates successfully complete their programs and where they are in life and where they started, and hear their testimonials and see kind of the history there, it's it's not 100%, but it is certainly pretty dramatic statistically. And I think a lot of the judges that participate would sing the praises of the programs.
Well, it just brings up the idea that not everybody responds to punishment the same way. I mean, some people respond to timeout.
Sure.
And some people don't, and they need some help, and they don't realize what they've done necessarily because that's the way they've always done it. So it makes sense, especially courts really do, that we're teaching and educating and moving you to a new place so you can choose different because of you're not in that same situation anymore.
Exactly. A minute ago, you mentioned the grant program that it was for jail diversion. I'd like to speak a little bit about some of the grant money. Not only because it's a very complicated system, money's coming from everywhere, from the Center for Disease Control and the federal government, and the Department of Health and Human Services, and everywhere. Right. And so some of these programs, the Texas Targeted Opioid Response, I don't know if it's TTOR. Do y'all call that TTOR?
TTOR is how it's referred to.
Okay. It sounds like Thor, and I like the way that sounds. It sounds powerful. Under Texas Health and Human Services produced a report in August of this year that details some things about federal grants to the state of Texas that we'd like to visit about for just a few minutes. According to that report, Texas has received over $176 million in grants across 4 categories: state targeted response, state opioid response, Strategic Prevention Framework for Prescription Drugs, and a First Responders Grant. The lifetimes of those grants vary, with the Prescription Drugs Grant beginning in 2016, and some of these have lifetimes extending into 2021. How is your work related to these grants, if at all, and possibly the extension of the grants? Also, do these grants ever impede the progress of your bills?
You know, it's interesting. The timing was very interesting for our committee's work, because a lot of the TTOR or federal grants sort of coincided with the work our committee was doing, and the president came out and declared opioid crisis as a public health crisis, which had significance for funding for programs and initiatives across the country, including Texas. So I would say that it affected it from the standpoint, in a good way, because it affected it from the standpoint that we weren't on our own. We weren't trying to figure out how to solve a problem on our own and necessarily dedicating more resources. You know, when we're talking about $176 million in federal grant dollars just to Texas, you know, that is significant money. That is significant, you know, in terms of what is being appropriated towards a problem that we all now recognize we're facing in the state. If we didn't have that, yes, we would be undertaking some of the same, probably, I'd say that, you know, I mean, very, very likely that we'd be undertaking some similar steps, but we might not have the same level of funding that we could dedicate to those problems. Or if we did, you know, that immediately takes away from something else. So again, you have to have the buy-in from a consensus of lawmakers from all over the state, which it would be difficult to do. You know, if you had to ask somebody, do you want to spend more money on public education, or, you know, taking care of our seniors and you know, lowering taxes, or do you want to put money into drug treatment programs? I can tell you that most of the time that won't, you know, that won't be, you know, it won't end successfully for drug treatment programs. It'll probably be, you know, lower on the priority list. And so to have the federal government, you know, offer some of these programs helps. It helps a lot. And, you know, to have things like a grant program that's going to be putting money to educate and equip our first responders, you know, that's just one of the areas you mentioned, but that's a great one, because honestly, until some of the testimony before our committee occurred, I didn't recognize the high level of risk that some of our first responders are experiencing with fentanyl on the streets, and how deadly that is, and how, you know, they must take serious precautions now like they have never had to take before in order to avoid, you know, contact even with fentanyl. And it's so much more common today than it used to be. So, you know, these are things that we just didn't have to deal with before. So it takes a while to educate your colleagues. It takes a while to get money in place to combat it. Meanwhile, first responders are having to deal with it, you know, every day. So to have a, you know, a partner, so to speak, in a federal counterpart say, this is a crisis, we are going to allocate the dollars, and we're doing it right now. You know, they meet all the time. We meet every other year for 140 days. And so it does help. I don't know that I'd say it impeded what we did, but what it did was, because, you know, it helped, you know, us be able to focus on some areas maybe that aren't addressed by some of these federal dollars. So it did help us, you know, in the legislative session, guide our efforts to be a little more precise about what we want to do, knowing that was out there.
I see. HB 1293 was a specific bill which targeted education in public schools regarding opioid addiction. That bill may be totally unrelated, but it seems like appropriation of funds might be related in some indirect way.
We had that bill and HB 18, HB 19. We had several bills that actually addressed not only maybe the introduction of an educational part of our curriculum with regard to substance use disorders, opioid addiction, but just behavioral health issues, you know, generally. For instance, in high school, through HB 18, you don't have to teach health, but if you do teach health and you choose to do that in Texas, you know, the bill says you ought to at least consider that, you know, health is more than just diabetes prevention and nutrition and cardiovascular disease. It also includes suicide prevention and anxiety and depression and substance use disorders and those types of issues. So, you know, I think that was good. I think we have much more emphasis on not just educating students at all ages and at a younger age, but educating our educators and our administrators about what they can learn to identify red flags and maybe children in crisis so that they can connect them with proper resources and treatment. We've actually now embedded non-physician mental health providers in each of our regional service centers across Texas. So like educational service centers here at Region 16, but there are regions all across Texas now that will at least have somebody as a backstop or a connector. If you're on a campus and you recognize maybe this student is exhibiting signs of substance use disorders or depression or something else, you want to get them help. Mm-hmm. You don't want to let that progress to a point where something tragic happens or the seriousness of that problem gets worse. You want to be able to connect them with somebody that can help them. And not every campus has the trained health professional or counselor even on staff. And so that was a step that we took in the last session. It really connects to this whole idea that all of these issues seem to be related at some level. And we just want to provide the resources in Texas that we can to address it as best we can.
Okay, so I was looking at an informational map on the Texas Health and Human Services website that's part of a syndromic surveillance program being funded by the CDC to help us track what we're dealing with here in terms of overdoses and deaths. Their public data only extends through 2016, but they did include county by county throughout the state of Texas in that informational graphic. So Bexar County, I think Harris may have been the most impacted, Tarrant, Dallas. Seems like HB 2707 might be able to help not just in rural communities. Funding, I believe that was funding some of these local health centers that have to do with substance abuse disorders, mental health places. I think they've got some one in Vernon, places like that across Texas.
Yeah, there's. Of course, we deal with these issues in a variety of ways. We have step-down treatment centers. We've got state hospitals. We have, all types of inpatient, outpatient resources. It just differs significantly from one region of Texas to another. The use of telehealth and telemedicine is actually something that, through legislation passed this session and last session, have made, I think, a big difference in the delivery of healthcare. To folks both urban and rural alike, and so I think that what we have seen is both a recognition generally that we have to do more, and so we have appropriated additional dollars to a whole host of programs, grant programs, programmatic changes, agencies and services. I mean, it's been aggressively pursued over the last couple of sessions, and but what you've also seen are just collaborative ideas. A lot of good things that can happen. As I mentioned at the beginning of this podcast, we didn't really have to pass bills to see happen. Mm-hmm. Some very good ideas are happening through, again, medication take-back programs and things that, don't require us to get involved necessarily or to pass a bill, but, can happen at a local level to really affect both the education of the community, the supply of opioids, alternatives to medication, some things that if you don't need to take the medication for longer than 2 days or 4 days or 10 days, don't do it. And I just, have to believe that all of these things working in concert with one another will make a measurable difference and prevent some opioid deaths and overdoses in the future.
So something that we were talking about, we're like, there's always seems like there's just an easy way to fix it. Why don't we just get rid of it? Get rid of opioids, right? It's causing, we know all the bad stuff. We know what it's binding to. We know that it's causing very addiction very quickly. So why don't we just get rid of it? We cannot prescribe it anymore.
Boy, that was that would be a scary thing. And again, I think that was the fear of a lot of Texans when this committee was formed. I can't tell you the number of emails and phone calls and letters that our office received saying, I suffer from a chronic condition that is only managed through my, ingestion of certain pain medications, including opioids. And, I think that there is a justifiable medical and appropriate use for opioids, no question. And so that was never the intention, is to just say we're going to cut, all use of opioids and take it off the shelves and prohibit the prescription of them. But, there are people out there that think, well, we should just do that. And that was really never something that we even evaluated. In fact, it was quite the opposite. What we wanted to do is make sure that we were managing the problem where the problem existed. And it was never under the care of a physician for management of chronic pain. It was always almost entirely, self-medicated, black market, non-knowledge of how long somebody should take an opioid for acute pain before they become addicted. And in some cases, and you mentioned it, it can happen really quickly. I never realized that some people can become addicted to their opioid medication within a couple of doses. I mean, just a day or two, and all of a sudden that's the case. Now, not everybody responds that way, but it can happen. And, addictions are quite serious. And so, and that leads to other addictions. It can. Mm-hmm. Certainly we have read and seen and heard from individuals who, went from pain medication and not being able to get it anymore to finding, other ways to treat their addiction, heroin, for instance. Mm-hmm. And statistically that's making quite a comeback, and so that's a bad thing. And so we obviously are keeping an eye on how to reduce that as well.
So interesting. So the scheduling of some of these drugs, where does the benzodiazepine topic play into this?
We heard testimony about, I guess, midway through the committee's work about what was, I guess, referred to as the Houston cocktail. It was the combination, and I don't remember why it was called that at the time. Maybe that was the person testifying was from Houston, but because that's not a name I think anybody would want to have associated with the actual underlying substance. But it was the combination of three drugs, and I'm going to forget exactly. It was a benzodiazepine along with an opioid, and I can't remember the third component, but it was extremely dangerous because, it slowed down your respiratory system. People who were engaged in this very dangerous, concoction or taking it often died because, it was such a, dangerous combination of drugs. And so any one of them by themselves can be obviously classified as a dangerous substance, but you start to combine these different drugs. And I think the knowledge of what each one does to your body, your nervous system, your respiratory system, is just generally unknown. And so, I don't think, again, this was often done on purpose, but what would happen is either people would do that, because they were addicted or wanted to, try that, or maybe they received one drug from one physician without it being known to another physician. They got it, didn't know the qualities or how they would interact with one another, and then ingest those drugs together, and then it created this dangerous condition. So, again, I think we're much further down the road to being knowledgeable about, the side effects of dangerous conditions, the addictive qualities, all that today than we were even a few years ago. But this is not a time to let our foot off the gas. We have to absolutely continue to put pressure, on our prescribers and our patient community and pharmacists and, the folks that are going to be in contact with people who are going to be taking this for acute pain on a regular basis so that they don't find themselves, again, in a situation where they're going to become addicted.
Well, I have kidney stones. And one time we were in Santa Fe, and they put me on morphine immediately. And my parents were like, nope, we're going to go back to Amarillo because we don't want to have it here because I had to get it removed. And they took me, I was on morphine for probably, 3 hours, like the drip. Mm-hmm. And because it felt really good because my kidney stone hurt. And I was actually experiencing withdrawal symptoms after that.
Yeah.
And I could see the reason people get addicted is because they don't have to deal with the way they feel afterwards. Sure. And so they just do it again and they do it again. And that's why I think one of these things like morphine, opioids, all of it they get bind to those receptors so quickly that they cause a really painful withdrawal and people don't want to deal with it. And that's why we see it so quickly.
Absolutely. And we did focus somewhat on treatment in our committee's work. It was a lot easier, I'll be honest, to say, what can you do on the front end of the problem, to educate the public or to reduce the supply, or to limit, improper access and educate our prescribers. All those things were kind of definable in a way that was much easier from a legislative perspective than dealing with the hundreds of thousands of Texans who are already addicted. What can you really do? And so we did make, I guess the what I would consider to be a gold standard in treatment, a medication-assisted treatment protocol, more easily obtained without a prior authorization. We did, try to address that because I think, again, if you have, withdrawal symptoms, if you're addicted, you're trying to come off of that. It's important to have probably, for most people, not everybody's going to react the same way, but I think at least our understanding as a committee was most people are going to favorably respond to both some medication, but also some good counseling, some good guidance. It's not just one, it's not just the other, it's a combination of both. And in many cases, I think that's very successful and when it's implemented correctly. So, we tried to make some headway there too. It's just a much more difficult area because everybody's so unique and how they respond and what will be paid for and how much it will cost and who's providing the service that I think that's an area that will continue to get some focus.
I just want to clarify, I was not addicted.
That's good to clarify, sure.
Because I might hear it from some of my students, like, what?
Well, Representative Price, thank you so much for being on our program today, and that's a heartfelt thank you. This is a very dynamic, complicated issue. It's an issue of our time. It's up to us to resolve it. If people made it, I believe it was John F. Kennedy said, if people created the problem, people can figure out the problem. And so together, working not only at the college, but you as a policymaker at the state level, working in conjunction with your colleagues, working with individuals in the health industry, with individuals across every single field and every single profession. If we can all pull together, we really appreciate your time. It's obvious how vast this problem is by just the varied topics that we brought up in the last 45 minutes. So thank you again for coming onto our program.
It's been a pleasure. It's a quick 45 minutes. I can't believe it's come and gone, but I really enjoyed being on your show. Thanks for the invitation.
Thank you so much.
Thank you. All right, everyone, thank you so much for your time. We'll see you next time.